All right, Dr. Pogachefsky, thanks so much for doing this. My first question that I have for you is tell the audience, just a little bit about yourself and how you got started in the community.
Yeah, thank you so much for having me on. And I'm curious to learn from you more about this podcast as well, but I'll introduce myself a little bit. My name is Haley Pogachefsky. I am an occupational therapist. I work with kids and their grown-ups, and I help them find more balance in their lives so that they can participate in all the activities they want and need to do. I work with the children on specific skills, and then I work with the grown-ups on how to help their kids and how to work with the kid that they have because a lot can come up for parents around, expectations for their kids and so part of my work is really diving into this is the child you have, how can you best support them and also keep yourself um, regulated and happy? And I got into this. I was teaching middle school special ed at a school for kids with mental health and behavioral health challenges that their districts couldn't support. And I was really interested in how OT brought all these elements of play into the lives of these middle schoolers who were so afraid to play in other settings. And in OT, they could really play and let loose. And I just loved seeing that and wanted to be a part of it myself.
hmm So, Haley, tell me a little bit about some of the work that you do now in your current role.
So now I meet with kids and their grown-ups. So a lot of the time I encourage grown-ups to play as well. And I'll meet them in the clinic and the child will come in often with an idea of what they want to do. And the clinic is just this big, beautiful, bright, colorful space with lots of games easily accessible for all the kids. So it's really exciting for the kid to be able to come in and control what we do. And so being child-led is really important to me because kids don't get a lot of opportunities to be in charge and in control of their lives. So I really prioritize helping the kids um, take ownership for the space and for the session. And I use that as a vehicle to explain to their parents and collaborate with their parents on what's going on in your kid's head right now, or, are there any opportunities for your child to do these activities or something similar at home, and collaborating with them to figure out the best way for the child to get all of the sensory input that they need in their home environment.
hmm Now, let me ask you this, because I talked to several psychologists and they've worked with a variety of populations.
Mhm.
Mostly they work with kids, some work with adults, teens. So I'm wondering from your standpoint, what is it like working with kids? Is it like very different compared to working with adults? I'm not sure if you worked with adults or teens, but could you give an insight into that?
Yeah, so I work with kids of all ages. So I'll see a 2-year-old one day, and then the next day, maybe I'm working with a 15-year-old. And so the experience is really diverse in terms of what I'm doing hour to hour, minute to minute, even sometimes for some clients. Um, I have worked with adults in a hospital setting. I worked in acute rehab, and it was very focused on activities of daily living. We call them ADLs. So, like, can
hmm
you go to the bathroom? Can you get yourself dressed? How can we maximize independence so that you can take control of or ownership of your daily routines? In OT, with kids rather, we're thinking about the ADLs and the daily activities, the daily routine, but it's a lot more play-based. So it's instead of like, we're looking at the physical skills of like, can you physically get to the bathroom? Is the bathroom able to accommodate any equipment that you need? But it's also about bringing play into the toileting experience so that kids are motivated to be independent or to participate in it and feel like they have a sense of control and ownership over their lives.
How do you incorporate play?
Um, that's such a good question. It really depends on the kid, and that's in grad school, we used to always joke that the classic OT answer is it depends. And here I am saying it. But I'll give a couple of examples. For one kid, we'll bring in toys, and that's enough of play. For other kids, we'll read a story about going to the bathroom or kind of act it out and use silly voices. Um, will use puppets to kind of demonstrate how toileting works or social stories so that they understand like what's actually going to happen and there are no surprises there on what's happening with toileting. Um, One kid has a really hard time with my bathroom at the clinic because the first time he came into the clinic, there was a spider in the bathroom. And so ever since then, every time he comes into the clinic, he says, I'm not going to use that bathroom. And that's fine if he doesn't have to go to the bathroom, but if we can be silly about like, well, what should we do with the spider if we find one in there and like um talking to the spider in a silly voice or saying goodbye, Mr. Spider, and then going back
Hmm.
into the bathroom. That kind of thing. Can humor and laughter can disarm that sympathetic nervous system response that happens, right? Our fight, flight, freeze response. So if we can incorporate laughter, smiling, play into moments that are stressful for a child, it actually downregulates their nervous system so that they're able to turn on their thinking brain again.
I didn't know that. So, what sorts of modalities do you use when working with children and younger kids?
Modalities like interventions.
Like modalities, like I'll give you an example. A lot of the common modalities that I hear often from psychologists is EMDR,
Hmm.
um, ACT, ass assistive commitment therapy,
Hmm.
all that kind of stuff. It's kind of the general sort of um mental health term. So what those are the modalities that I'm referring to.
Yeah, so that makes me think of like what kinds of approaches do I take or what kinds of
Hmm.
theories do I draw from?
Yeah.
So one of them is internal family systems, which is a mental health practice that posits the idea is in our minds we have multiple parts. So, for example, um, when I'm watching TV at night, I always have a part that wants to keep watching another episode, another episode, another episode. And I have another part that says, no, Haley, we have to get to bed. We have to wake up in the morning. Like we're gonna feel bad if we don't go to bed right now. So I have these two parts of my mind, and they may seem conflicting, but they're both trying to help me in the best way they know how. So IFS takes a look at where do those parts come from? Where did they get the ideas that they have about what we need to do throughout the day? And how do we help them see the most adaptive and beneficial path forward?
Oh, because is that the only modality that you use, or do you like use more than one?
Oh, I totally use more than one. Often, so I really ascribe to child-led behavior or child-led session planning. So I don't come in with an idea of like, here's what we're gonna do. I always let the child lead. And so that's one sort of theory that I draw from. Another one I use is I guess the child-led comes from DIR floor time, and I'm not specifically trained in it, but I do pull ideas from it. Um, Another that I use is the sensory model. So looking at the sensory system, which is we have eight sensory systems, right? We have the five that we know, touch, smell, sight, sound, um, taste. those are kind of the well-known ones. Then we have three other ones. Proprioception, which is, do I know where my body is in space? Where are my arms? Like if my arm is over here, can I match it with the other arm? That's proprioception. Vestibular, which is our sense of balance and movement. So that's, some kids are really into spinning or really love the feeling of running. That's all the vestibular input. And interoception is what's happening inside the body. Do I have to pee? Am I hungry? Am I angry? Um, and that's the basis for understanding our emotions. And so there are sensory modalities that I'll use that work with all of the sensory systems to help make sure kids are getting their needs met. And parents too. We all have senses even as we grow. We think about it with kids, but parents and families all have those sensory experiences as well.
Hmm. Which one has been like your favorite to use?
Oh gosh. Um, I learned so much through sensory play from kids. I think um like I said, it's the basis for understanding the rest of your physical and emotional experience. And so no matter what I'm doing, I always have the sensory framework in mind.
Hmm. What have you learned from, doing this kind of work? Like, what have you learned from working with kids and younger children?
That they know what they need and they just need the space to get it safely. So, for example, a child who is angry might rock back and forth. That means they need vestibular input. Another child might start to hit. That means they need proprioceptive input. Um, and kids will do automatically the things that they need to do in order to regulate safely. And it's the adults actually that teach them, no, it's not safe to hit. No, it's not okay to rock because it looks weird to strangers. Or, you know, no, you can't eat that. You can't touch that. You can't do that. And so kids learn as they grow that they need to suppress those instincts. And what we do through OT, what I like to do through OT, is to help them find those instincts and just figure out, like, okay, you can't hit your mom, but you can hit a pillow. Um, Maybe it's not safe to rock back and forth in one setting, but let's, use a swing and get that rocking sensation in a safe way. So it's really all about going with what the child knows they need. And I have learned that every child knows what they need. They just need a safe space to remember.
Hmm. And I always ask therapists this, like what is one thing that on your bucket list that you would like to learn or that you're curious about?
I'm really curious about pelvic floor therapy, which is a more like physically based modality of OT, but it's just an it has to do with so many of the daily functions that we all do, right? Like there's um, toileting, eating, sexual relationships, birthing. There's so much that starts with the pelvis. So much movement starts with the pelvis. And so I'm really curious to learn more about pelvic floor therapy someday.
Hmm. And lastly, what can people take away from this conversation? How can incoming psychologists who want to work with children, how can they be prepared to really work with this population?
I think the biggest thing with occupational therapy is just the fact that it exists. So many people don't know who OTs are or what we do. Um, and so my hope is that through this conversation, people will recognize that maybe people who are curious about a professional path will see that OT is an option and that we do so much. There's the sort of therapeutic psychological component, there's a physical component, there's the intersection of the two. I like to say that I work at the intersection of physical and mental health. Um, and I think that's really true of all OTs. And so my hope is that people will see this as a potential field that they can be curious about.
Mm-hmm. All righty.